Good afternoon, everybody. Welcome to this afternoon's symposium sponsored by Medtronic on left main bifurcations and renal denervation. My name is Tan Hui Chim from the National University Heart Centre, Singapore. And today we're going to be focusing on the following learning objectives. Number one, we're going to talk about the treatment strategies and recent evidence for left main bifurcation. And number two, we're going to also learn about the latest Malaysian group consensus on renal denervations, which is, I can tell you, is a very well-written consensus paper, and we will have much to learn about. And number three, we're going to review a patient-centered clinical judgment and individualized treatment plans for left main as well as renal denervation for patients with hypertension. So in this particular session, we would like to encourage everyone to participate. So you can actually log on to the AICT-AsiaPCR website and then submit your questions and so forth, and we'll try to reply and answer your questions as much as we can. We do have a chat master online to respond to whatever questions that you may have. So with me as a co-discussants, on my left is Dr. Chin Chi Teng from National Heart Centre, Singapore. On my right is Dr. Aaron Wong, also from National Heart Centre, Singapore. Besides him is Dr. Paul Ong in private practice, Maui Novena. And Dr. Chu Kim Hui from CBL Central in Malaysia. Now, we also have two of our Thai colleagues logging in as a virtual discussant, Dr. Natawut Bombraparut online, hello, and Dr. Nitish Naik as well, joining us. Hello. So without further ado, I would now like to invite our first speaker, Aaron Wong, to share with us his strategies for success in left main stenting. Aaron.
Okay, thank you for the introduction. My topic is strategy for success in left main stenting. I have no potential conflict of interest to declare. Unfortunately, there is no guideline for a strategy that guarantee success for left main stenting. However, guidelines do provide indication for left main stenting, preferred stenting strategy for certain bifurcation anatomies, and recommendation for intravascular imaging. However, each patient is different, and the left main lesion is unique as well. So therefore, there is no single strategy that can fit all. So I think the key is the individualized strategy based on evaluation of patients' comorbidity, lesion complexity, equipment availability, and operator experience. So for a successful left main stenting, strategy planning should start from the time of decision to perform left main PCI. So I just list down 5 pointers, and I'm sure there are many strategies that the panelists can suggest as well. So the procedure planning, the importance of imaging and physiological assessment, stent strategy, stent selection, and some crucial techniques that make left main stenting a success. So left main stenting is always complex and high risk, and CABG is always an alternative. So it should never be performed on ad hoc basis for the following reasons: because it required recommended heart team discussion, patient need informed consent, strategy planning, risk of long-term DAPT, and also medical legal issue. And the indication for left main stenting, as you know, the very poor outcome for medical treatment and surgery is a better option. And SYNDEX trial has shown us that the patient who have SYNDEX score more than 33 is better treated with CABG. And it also guideline also recommend heart team decision and also what local expertise available. And at the end, it's a patient preference that actually decide the treatment. What does the guideline say? Actually, I like the 2018 ESC guideline. It's very simple. It's based on SYNDEX score. If it's 0 to 22, both are class 1 indication, and if it's more than 33, CABG is better. And the recent guideline for AHA guideline is just a little bit more wordy, describing the same thing. So next, you have to assess the patient, lesion, and procedural risk assessment. So patient with diabetic, very importantly, the LV function, whether it's a CKD, high bleeding status. And this is the Interventional Council of ACC, which describe the criteria for high-risk PCI that may require mechanical circulatory support. And you have to assess a lesion, the Medina classification, simple versus complex lesion by the definition score, and also the bifurcation of the angle. We decide which strategy to do, and also whether you're doing the non-left main lesion at the same time. So planning PCI strategy assess, it can be via radio or femoral, but if you require a larger guide for more complex, larger guide is preferred for more complex lesion, especially you require 3 wires, 2 simultaneous stents, or larger rotablation burr. And also, larger guide have less wire wrap, and you can reuse the balloon and can be cost saving. The guide selection, it can be either supportive or non-supportive guide, but personally I preferred supportive guide because crossing the side branch may require more support. And guide wire selection, there's a paper published that for side branch, gel side branch, it's preferred to use polymer coated because the microscopic damage to polymer coated is much less as compared to non-polymer coated, as on the table on the right. So the roles of adjunct modalities in left main intervention is important because intermediate left main lesions are very difficult to assess. So it will give us when to intervene, how to intervene, and how to optimize the lesion. IVUS is in all these 3 categories. OCT have limited data and some technical limitation, and IFR has small observational study, not enough data to recommend use of IFR in left main. So when to intervene, it is very well correlated that when the MLA is less than 6, it is significant. But in Asian population, maybe this cutoff criteria for MLA is much lower, about 4.5 to 4.8. And I'm not going to belabor this. IVUS is very helpful in lesion preparation, landing zone of the stent, reference vessel diameter, stent size, and also the stent length, and also deciding the post-dilatation NC balloon size. And most importantly, the target minimal stent area have to be more than 90% of the, compared to the closest reference segment, proximal and distally. So this is an imaging criteria for optimal intervention, which has been published more than 10 years ago, the 8765 rule for left main bifurcation. So although there is no large randomized trial to show the IVUS is beneficial, but meta-analysis of 11 left main DES studies show that IVUS has beneficial in left main intervention in terms of all the endpoints of all-cause mortality, cardiovascular mortality, stent thrombosis, MI, and TLR. So recently, the Rolex registry actually had left main stenting using onyx stent and have excellent result with a primary endpoint only about target lesion failure of 5.1%. And in the subgroup analysis of angio-guided PCI versus IVUS or OCT-guided PCI, the IVUS-guided, imaging-guided PCI do much better than angio-guided PCI. Again, solely enforce that imaging is very important in left main stenting. And the guidelines, the recommendation is class 2A indication. It may never be class 1 indication because there is no large randomized trial comparing IVUS and left main. So stenting strategy, provisional versus 2-stent technique, I just summarize this in this one slide. Actually, I'm quite impressed that this author, Rab, published in 2017, actually predicted the results of the all the trials was published after. So the left main bifurcation lesion, you're dividing into simple versus complex. Simple, provisional stenting. If it's complex, based on the definition criteria, more than 70%, and all lesion more than 10% of the side branch, and plus 2 of the minor criteria. For Asian Bifurcation Club, it recommended 2-stent technique based on DK Crush 5 and also the Definition 2 study. Although Definition 2 study is not purely left main, but 30% include the left main, and 78% of the 2-stents technique is DK Crush. Yeah. So with the European Bifurcation Club, actually for complex lesion, the recently published trial, EBC main, use 2-stent technique versus provisional stenting, actually show that provisional stenting actually is as good as 2-stents technique. It is interesting to look at the detail of the EBC main study using the Resolute Onyx stent. Actually, numerically, the systematic 2-stent technique actually fare a bit worse than the stepwise provisional. As you can see, this is truly bifurcation lesion. The 90% is 111 Medina. But if you look at the 2-stents technique, only 5% is actually DK Crush. The rest are either Kulok or T or TAP. So the difference in recommendation and the trial result maybe could be due to that of the operator's experience and skill and different techniques. So therefore, it is very important for the operator to use a technique they're comfortable with. So for stent selection, for left main stenting, stent selection is especially important. Stent with short DAPT indication is good because as a safety net, just in case we need to stop the DAPT for some reason. Stent that have shown good track records in randomized trial or registry, the XL, EBC main, Rolex registry, or TK Crush. TK Crush actually mainly uses Zions and Endeavor, Resolute Endeavor. So maximum stent inner diameter that will match both the size of the left main and LAD or SERP. Yeah. And also maximum side branch diameter for side branch access, especially for culotte technique. Stent design that minimize longitudinal stent deformation, especially with osteo left main stenting. So this is a table that we have in my lab that have the maximum expansion for all the stent available. It's a good reference to see what the size of the stent that can expand to. And recently, there are dedicated stent design for left main stenting, the Megatron, and also the Resolute Onyx 45 to 50. And they have updated their maximum stent expansion size by 0.25, and the maximum now can go up to 6. And also the maximum cells side branch diameter is quite big, more than 3.5, and it's good for culotte stenting. And some important techniques is crucial for success. Firstly, the lesion preparation, especially the osteo circ, NC balloon scoring, cutting balloon, or even OPN may need to use to prepare the lesion. If needed, rotablation or IVL. POT is vitally crucial for success and reduce complication. It prevent wiring under the stent straps, deformation of the stent, also easier rewiring and crossing of balloons across the stent straps. And final kissing balloon is a must for a two stents technique. So for take-home message, for successful left main stenting with good outcome, planning should start from the decision to perform left main stenting. So strategy that will reduce complication and ensure good outcomes are intravascular imaging, understanding the stent designs and clinical data, and also some important techniques like POT and final kissing balloon. Provisional or two-stent strategy should be individualized and depends on a very careful evaluation of angiogram, imaging, physiology, as well as assessment of the patient. Most importantly, it should be the operator skills, experience, and techniques that he or she is confident with that decide the stenting strategy. Thank you.
Thank you very much, Aaron, for that very comprehensive coverage on the left main stenting, not just in terms of the procedural techniques, but also looking at some of the trials to understand what do we make of it. So now this is going to be an interesting Q&A sessions here. So I'm going to start off with Dr. Nitish online from Thailand, if you can hear me. Now, having heard what has been presented, and also probably looked through all the literature with regard to left main PCI and so forth, in the last 5 years or so, has your approach to patients with left main PCI changed? Dr. Nitish?
Yes, definitely you are now ready to take patients for left main intervention more frequently, because there are a large group of patients for whom the decision for left main intervention is dependent not only on the clinic, not only on the anatomical characteristics, but a whole lot on the clinical characteristics. And now with the availability of new generation stents, with the availability of better DAPT, with the better design of stents, now it is important that we are able to address these patients very carefully, because left main stenting is there in nearly 5 to 7% of our patient population, and it's an important area where interventional therapy has a large role to play. Because surgical intervention, though it's as a heart team approach is very important, we should recognize there are a whole lot of patients in whom surgery is not possible due to frailty issues and many other clinical factors. So I feel left main intervention has become a lot more safer, it's become a lot more efficacious, it's a lot more predictable. Yes, the strategies have been a little more better defined when it comes to DK Crush. It had showed that the two-stent approach was very useful, but I think so that was a more difficult population because the syntax scores were higher, the sideband osteal lesions were tighter, the sideband lesions were longer. Whereas EBC main showed us that in patients who have got a milder degree of disease in the side branch, a provisional stenting approach can work. as good. What needs to be shown is the role of imaging, and I think so the DK Crush 8 will address some of these issues, and that will make us a whole lot wiser when it comes to deploying the right tools for doing left main intervention.
Thank you very much, Nitish. So you mentioned the very more predictable outcomes from left main PCI. Paul, so has your threshold for left main PCI changed in the light of recent evidence? Are you more willing to undertake more complex left main PCI lesions? And are you also doing more two-stance strategy for left main PCI? What's your take?
Thanks, Hui Chim. And thank you again, Aaron, for this tour de force of the left main trials and the techniques. I also echo what Nitish said earlier. I think 5 years or so ago, we are still sending quite a large number of patients for bypass with left main. We still do that if the lesion is really, really complex. But I think some of it is patient choice, and you increasingly see a pushback from the patient say, hey, can't you just do this with stenting? And the clinical trials, some of it do support it. One practice change I certainly notice a lot more is when performing complex left main especially, is we're using imaging a lot more. I'm actually surprised that the guideline only give you a 2A recommendation using IVUS in left main. I would have thought it should be class 1A by now. The technology also improved a lot, Hui Chim. I think when we're talking about two-stent technique, Aaron earlier on mentioned about the stents are now bigger and stronger. But also, a lot of us in this part of the world, we do transradial. And when we are targeting two-stent technique, a lot of time we want to have a 7 French guide. And the last few years, with the introduction of these slender, thinner sheaths, allowing us to put 7 French guide in certainly helped. And then, of course, the technique that early on we spent quite a lot of bit talking about. Once upon a time, the final kiss is final. But final kiss is no longer final because we have a POT. So POT is certainly a new term that is introduced to the fellows for the last few years. And now it's almost mandatory that you need to do a final POT before you actually walk away from the case. So yes, I think the simple answer is we are all doing more complex bifurcation involving the left main because we simply have the indication, the technology, and the technique to do a better job.
Thank you, Paul. So, Kim Hui, can I check with you? So, the two biggest trials of left main PCI in the last few years have been the EBC main and the DK Crush 5. And both are superiority design trial. One trial shows that one strategy is superior to another, and the other trial says it's a neutral findings in EBC main. Do you see these two trials as being complementing, or do you see this trial as being contradicting in terms of its findings? Because, how do we place DK Crush now, or two-stent strategy versus provisional?
Yeah, I think it's a great question that we've been debating for a while, but I think that to take both trials together, it is probably inappropriate to say that based on these trials, one technique is better than the other. I think both trials are similar and different in many ways in terms of perhaps the patient population, the complexity of the lesion, as well as the technique that was deployed. As Aaron said, in the EBC main, DK Crush was only done in 5%, whereas it was 100% on the other side. So I think you have to individualize sort of phenotype of patient, and then you decide which is the best strategy for the patient. So I wouldn't say that one is better than the other. They are probably complementary in the sense that you want to have perhaps a simple left main bifurcation, maybe a stepwise layered provisional may be good, but do not be sort of concerned about using a two-stent strategy, using a good technique at DK Crush if the indication is appropriate.
So, Chi-Ting, what do you think? What accounts for these differences in findings between the EBC main?
Yeah, sorry.
And
So
DK Crush?
yeah, I think that's the toughest question so far. So I think like Kim Hui has already mentioned, there are similarities and there are differences. So I think actually reading the actual paper itself is quite illuminating. I think they looked at really very different strategies. So EBC main, most of the two-stent strategies are Q-Lot tap, whereas DK Crush, as Kim Hui has mentioned, is exclusively DK Crush. But if you look at the KM curves in the DK Crush 5, a lot of the primary endpoint is driven by revas at about 1 year. Okay, and we have to ask ourselves why they had extra revas at 1 year. I think that's not really been very clearly elucidated. But I think what we can take back from both the studies is that if you follow a very systematic approach to doing left main, And if you are very clear in your strategy, as Aaron has already mentioned, then you're going to be very likely to get a good outcome. Because I think both the overall results of both the trials show that actually overall patients do get a very good outcome from whatever stenting strategy we actually employ in the left main at the moment. And I think the final take home is that from the EBC main, we know that stent selection actually maybe does not really impact that much upon our stenting strategy. So in EBC main, we used Onyx for all the trials, for all the patients, and both arms had a reasonably very good outcome. So that's really my take home. Thanks.
So my personal take here is that there are selection bias and there's a performance bias involved in these two different studies. And actually see both of them as being complementing, because if you look at the EBC main, it is a low-risk population. It is a simple left main PCI, low syntax scores and so forth, no CTO. On the other hand, when you look at DK crush and you start to subdivide them into simple and complex, the benefit of a DK crush only comes in a complex lesion. So suggesting to me that actually in the simple approach, a provisional strategy is a okay strategy, but when you go into very complex lesion, perhaps complex lesions requires a two-stent strategy in those patients. So I'd like to ask Dr. Natterwood, so based on all these trials, do you think that it is, the stent that we choose should be very platform dependent? So should we be using only stents that have been used in trials such as Resolute in Rolex registry, or should we be only using Zions in the Excel stent? So is this a platform-specific stent choice that we should be looking at?
I think it's very important question. I think as Dr. Aaron Wong had mentioned about planning for strategy, I think you need to understand it well. So I think you need to understand the stent you use. I think Onyx have a lot of advantage. I think you can expand very maximum diameter up to 6, have the good side branch approach when you do the two stent technique, and also have the shorter indication. So I think they have a lot of advantage of Onyx, but I don't think you have to go to the platform, but you need to know, because this stent, this market, when you deploy the management, you will have to go precise and position. You need to understand the stent. But in the development, I always 100% imaging and Onyx is stent.
So Aaron, do you agree that Onyx is your stent of choice for left main PCI? And secondly, maybe in high bleeding risk patients, based on Onyx 1 trial, perhaps, do you think Resolute Onyx might be a preferred choice?
Yes, I mean, it is very important. Like I mentioned before, it's a safety net, so that if for some reason that the patient need to stop the DAPT and bleeding problem, then you feel more comfortable that this stent had the short DAPT indication.
Yeah. So with that, we'll come to the end of the first sessions on the left main strategy. We're going to move on to the second sessions and switch tune a little bit. We're going to talk a little bit about renal denervation. And for that, I would like to invite Dr. Chu Kim Hui to share with us his 2022 Malaysian Working Group consensus statement on renal denervation. Kim Hui, please.
Thank you very much, Hui Chim, and thank you for being in this session. And thank you, Medtronic, for making this session possible. So I'm going to share with you what the Malaysian group has come up with in terms of a shared consensus statement on the position of renal denervation. Over the last few years, you've seen a number of consensus statement, position statement on the use of RDN. Our aim, of course, in this year when we published this, was not to duplicate what has been done, but of course, we realized that this technology needs to be made available to a broader group of physicians managing high blood pressure, including physicians in the internal medicine specialty as well as primary care. And most of the previous guidelines were very specific to cardiology or nephrology subgroups. This is the paper that was published in the middle of this year. We had a group of people under the auspices of the Malaysian Society of Hypertension and the National Heart Society to come together. We had leading as the primary author, actually is a primary care physician who's from the Hypertension Society. We have nephrologists, of course, cardiologists involved as well as a clinical pharmacologist. So over the last years, when we come up with this, we thought we had to do better because up to 30% of Malaysians are hypertensive. And to have the technology, even if it's available, we know that the uptake is going to be slow. One of the key things is actually to have regulatory approval for this procedure. And to do that, not only that, we also need some provision for physician reimbursement. So having a statement that comes from 2 medical professional bodies, we might be able to expedite the access of this technology to the needy patients. So if you look at it properly, we do very poorly in terms of our prevalence of hypertension. There is a very popular slogan in Malaysia called Malaysia Boleh, means Malaysia can. Of course we can, and we can be a bad example to our neighbors all the time, because not only 30% of the prevalence of hypertension, but only half of these are diagnosed. So the actual prevalence may be actually even higher. And those who are known to have hypertensive, you might say that 90% are treated. But the sad part is, more than half are not at the blood pressure target. So the key points of this Malaysian consensus document will be to identify the most commonly indicated patients for renal denervation. These are patients with uncontrolled or resistant hypertension. We also expanded the indication to candidates beyond resistant hypertension. And we'd like to acknowledge a few key attractive features of this technology, as well as looking at the very important patient preference in the equation. So the first bit is actually to see who are the actual patients who truly have resistant or uncontrolled hypertension. And in this, we clearly sort of understand that if you look at the definition of resistant hypertension, there is 3 medications on board, including a diuretic, and still blood pressure not to target. It is not uncommon. In a public health sort of series, we see that about up to nearly 10% of the patients in the outpatient clinic may have a resistant hypertension. In a small series of patients referred for renal denervation, when they actually look at it, only 35%, 35% truly have a resistant hypertension. So we, in this paper, wanted to make sure that we truly do not sort of miss out the patients with resistant hypertension, as well as not misdiagnosing those with pseudo-resistant hypertension. So we highlighted the importance of measuring the blood pressure properly. We also want to highlight the prevalence of so-called white coat hypertension, which is not uncommon. In some series, we have had more than 50% of patients in the public health clinic having white coat hypertension, as well as making sure that the patients actually take their medications. After identifying patients who may have true resistant hypertension and also excluding secondary hypertension, then we will go on the algorithm of those patients still having blood pressure not under control to be considered for renal denervation. So in patients that we identified, that may be sort of relevant for this technology will be, of course, uncontrolled and resistant. But we also look at patients at high risk, patients with hypertension-mediated organ damage, or patients with existing cardiovascular problems like previous CAD or previous cerebrovascular accidents. The other part will be patients already on multiple medications because of multiple conditions, so there will be issues in terms of their medication, dosing, drug interactions, and so on. The next bit will be to look at the behaviors of the patient. Patients who are obviously not going to be adherent to your therapy, or patients who are unwilling to take long-term antihypertensive therapy. Of course, there are patients that are intolerant to the blood pressure medications, and we, in this sort of statement, did a bit more than what some of the guidelines do, because we do consider RDN for those with secondary hypertension if they are still uncontrolled despite maximal therapy. And of course, if patients whom we think may have sympathetic overdrive, which is the key sort of target of this technology, who may benefit from this technology, we can identify them by having patients with early morning hypertension, resting tachycardia, or those with obstructive sleep apnea. And of course, patients that comes in with repeated hypertensive crisis. So if you look at across the board, there are common indications to give RDN therapy, but in the Malaysian statement, we do expand that to patients with secondary hypertension that are uncontrolled, as well as those with hypertensive crisis. We acknowledge that this technology is very interesting and exciting. We can achieve what a good antihypertensive drug can achieve, that is about 5 to 10 millimeter reduction in the systolic blood pressure. If you look at the contemporary trials with our sham control, 5 to 10 millimeter millimeter mercury reduction in the blood pressure is going to be excellent, because it's going to translate to significant reduction in cardiovascular events and potentially even cardiovascular death. We also like the fact that one treatment and the benefit will be seen forever, always on 24/7, 24 hours a day, and it is durable, maybe up to 3 years or potentially more. Here in the Global Simplicity Registry, you saw that the reduction in blood pressure continues up to 3 years, whether measured in the office or at 24-hour ambulatory blood pressure. If you look at spiral hypertension, which is a randomized trial, up to 3 years again, time in therapeutic target, which is a new metric for blood pressure sort of control, shows that it continues, diverge early, continues to diverge over time up to 3 years without significant difference in the medication burden. Again, going back to GSR, if you express the time in target range in terms of percentage of days, again, it increases over time. And the fact that you can put the patients on the therapeutic range or the blood pressure target, most of the time, the higher percentage in green they are in the TTR, the greater reduction in events as well as potentially cardiovascular death. We also know that this would definitely reduce the medication burden of the patient. We want to reassure everyone that this technology is safe. Here in GSR again, despite having greater achievement of blood pressure targets, the number of medications do not increase. In fact, they may be on a downward trend. And the spiral hypertension, again, on 3 years, is actually almost the same in terms of the adverse events rate compared to sham control. This is an idea that is coming on board, that when you have a patient that's informed about the procedure, the benefits and the risks, we get them involved in the decision-making process. If there's patient preference, we might consider RDN if the patients are young and prefer to be on minimal medication. Patients are already on multiple medication and we want to reduce the pill burden, or patients who are very, very well motivated to have better control of blood pressure, which is sustained over a long period of time. Thank you very much.
Thank you very much, Kim Wei. Certainly a very comprehensive paper and a lot to discuss. So for a start, I'm going to ask Jiteng some difficult question again. Not that I want to pick on you, but probably the smartest around. So maybe just tell us briefly, how does renal denervation therapy work? And secondly, why is the results that we are seeing with Spiral HDN and Radiance so different from the Simplicity HDN-3 study?
Okay, thanks Wei Chim for asking difficult questions. So I think we can roll back a little bit about renal denervation. So I think the technology that Kim Hui has been telling us about for the last few minutes is really a percutaneous technology that is targeted at reducing the sympathetic drive, the sympathetic so-called overactivity of the body that contributes to hypertension. And we know that the sympathetic hyperactivity does contribute to hypertension. We know this from the past where we've had operations to remove sympathetic ganglia. We've had blood pressure medications that target specifically the sympathetic nervous system. All these bring down your blood pressure, and so hence the concept of this percutaneous treatment. And what happens in this treatment is that we introduce a catheter into the renal arteries because the sympathetic nervous system has nerves that run along the adventitia of the renal arteries, and then we perform denervation to reduce the overall sympathetic activity. And so going on to the second more difficult question, as we know, the wealth of the initial enthusiasm for renal sympathetic denervation came more than 10 years ago now, where the preliminary studies showed a very dramatic reduction in blood pressure amongst patients who had what we call resistance hypertension. So they had office blood pressures systolic above 160, taking 3 or more medications. And this was then examined in a more formal way in the Simplicity Hypertension 3 trial, where the procedure was compared against a sham procedure. And unfortunately, that trial was neutral, meaning that while patients who had renal denervation had a drop in their blood pressure, the patients in the sham control trial also had a drop in the blood pressure, and the delta, the difference between the two arms, was not statistically significant. Now, since that time, as Kim Hui has shown very elegantly in his trial, in his talk, we've had a lot of other trials that have shown actually a significant reduction. And so the question always has been, what happened in HTN-3? Why was there this so-called neutral result? And I think now that we understand a little bit more about the procedure and the technique itself, I think we now maybe drill down to two big factors. One is patient selection, and the second is obviously the procedure itself. So in HTN-3, perhaps the patients that were selected were a little bit not so well controlled. There was some variability in terms of their pharmacotherapy. In the more recent trials, we have had more regimented protocols where the patients were taking a really strictly observed medication regimen. They had regular drug testing, meaning urine and blood testing, to make sure that they were taking what they were supposed to take. So hence, there was less variability in terms of the patient population. And the procedure itself has really changed dramatically. So the initial catheter that we used in the HTN, in the Simplicity studies, has now changed. So the spiral studies now use a very so-called next level type catheter, much easier to use, delivers much more ablation points. We now ablate much more of the renal artery, hence targeting more of the sympathetic nervous system. In the Simplicity trials, in HTN3 specifically, the number of so-called ablation points was less than 10. And in the spiral studies, this is much, much more. So maybe more intensive treatment also does play a part. So I think what we can go from now is, based on Kim Pui's very elegant talk, is that the more recent studies comparing to sham, renal denervation does bring down the blood pressure in patients in a whole variety of different subset groups. So I think that's where we stand at the moment.
Thank you very much. That was quite comprehensive. But one thing that we also know now in recent times is that the neurosympathetic nerves actually don't just locate in the proximal part of a renal artery, which we were targeting in the earlier ablation. Actually, there were more in the distal. So now the latest spiral is that you go to the distal part of the renal artery and starts the ablations from there. So that some new information here. So Paul, you have heard about this Malaysian's inclusion criteria, patient selection is fairly wide-ranging and so forth. Do you agree with such a wide-ranging inclusion of patients suitable for RDN? Mind you, actually, European Society of Cardiology only have one indication, which is patients on 3 antihypertensive and not getting the BP control. But here we have a lot more. So what do you think?
Again, I have to congratulate our Malaysian colleagues to come up with this, really nice consensus paper. I think personally, in my practice, I will probably still be a little bit reserved especially in the younger patients who are on minimal antihypertensives and then embarking on renal denervation. I will very much still more or less sticking to the patient who are have resistant hypertension. And when they approach me for that, and if that's what they want, and I would explain to them that this is a safe procedure, that's really important. I also tell them that it is an effective procedure, which is an addition to their current drug regime. It's not really there to replace their current drug regimes, but it's additional to it. It isn't always on, like Kim Hui mentioned in his lecture. So, for patients with site compliance issues, it would be a beautiful techniques. But I think some of it is also in terms of patient expectation management. Young patient hoping to come here and have renal denervation done to cure their hypertension, I have a little bit of reservation about that. Patients who have multiple drugs and expect REN to be successful and therefore completely removing all the drugs, I also have to taper the expectation. But by and large, now with more evidence coming in the latest trials, it is more convincing to actually go and tell the patient that the procedure is indeed effective, is safe, and potentially can save life.
So, Dr. Natterwood, what do you think will be the ideal patient for RDN in your country or in your practice?
Thank you very much. I strongly believe we actually have been did since 2012, and we have just published a paper on long-term the RDN in type population in evidence research as well. We have the longest follow-up for 9 years, and for 9-year follow-up, patients still have the persistent blood pressure reduction. And but in Thailand, because of the cost effectiveness, so I think we come down guidelines is ongoing for publication. So we focus on the refractory hypertension, patient with resistant hypertension with cardiac organ damage. I think that it would be a difficult choice to use just only medication. And as you heard about the long term of the Simplicity hypertension tree that are coming out, the previous trial was negative, but I think recent presentation in PCT that have been shown, I think in follow-up for 3 years, I think the results are significantly better. It's a probably offset effect. So I think problems are at Dr. Shi have been mentioned. I think with the simplistic tree, I think you compare between the device and medication, but on simplistic tree, I think you have in 40% of the case that change medication. So I think that probably why was negative at the beginning. But I strongly believe in the technology, and I think in the patient with resistant or refractory hypertension, they deserve for this technology.
Yeah, so I think for resistant hypertension, we have not much of argument here. But Kim Hui, coming back again to you in terms of managing patient expectations. So how would you tell the patients, how effective is RDN? Is it going to be 100% effective in everybody? And who are going to be the non-responders? And how frequent are the non-responders? And the second thing to think about here is that telling a young patient that, going for RDN instead of medicine, is that something that you think is going to work at this point in time based on the current knowledge and literature?
Yeah, I think as mentioned, managing expectations is very important. We also do not want physicians to do a hard sell on a technology when it's actually not the only sort of treatment. So patients need to understand why they're undergoing this. Basically to reduce blood pressure, and therefore they reduce their event rates and improve their outcomes. But because the technology at the moment looks like you're going to have the efficacy which is about the same as one drug, it's very unlikely that these patients with high blood pressure is going to go off medication, as mentioned. But maybe also likely not to reduce the dosing of the medication as well. But we are assured that most of these patients are going to have their blood pressure better control in the long run. The effects may come a bit longer, a few months to a year before they see the blood pressure reduction, but we've seen that data that it may continue to have blood pressure reduction over for up to 3 years. There may be patients who do not respond. Maybe up to 20-30% may not respond. So, but we try in these patients because they have no other option to better improve their blood pressure. With regards to younger people, yes, I agree with you. I think that's in a way in a soft sort of indication. We also do understand that from some of the surveys, patients, what they want is different from what their physicians want. Patients are willing to undergo the safe procedure, even though there's not a remarkable or dramatic reduction in blood pressure, because they want to take less medication. If they understand the limitations, good expectation, I think it's something that can be considered after a careful consultation with a very informed patient. So young patient, of course, these are not our primary target, but if they are indeed they are willing to undergo the procedure, they understand, I think it may be considered as well.
Thank you very much. I think you agree with me that this has been a very interactive educational sessions, although it's kind of short, but we have learned a lot about left main stenting from Aaron and the rest on the strategies, on the techniques and so forth. We also learned about renal denervation therapy from our Malaysian colleague. Certainly, I do believe that RDN is an effective therapy based on the current trials. It is definitely working as far as denervation of the sympathetic activity goes, and it is a durable effect as well that we are looking from some of the 3 years follow-up. So I think it's a very exciting technology. Obviously, we're going to learn more about it as we go along. But for now, this is something that we should be keeping in our radar and in the horizon. So thank you very much all for attending this afternoon symposium. I hope that you continue to enjoy the rest of the meeting. Thank you, everybody.